Hello everyone. As I told in the last class, I'm sorry, I'll keep my mask on and then I'll take the class today. I hope there wouldn't be any problem listening to me. If any, please message the attendance. Okay. Can you hear me, everyone? I hope you can. Yeah. So in yesterday's class, we have seen that the thyroid is a butterfly-shaped organ which is seen in the neck, and it is usually moving with deglutition. So when you find a neck in the mass and then you find that the mass is moving with the deglutition, then you know that it is thyroid, right? So we have seen that the thyroid has the major function of controlling and regulating the metabolism of the body, regulating the basal metabolic rate, and then it has the authority to maintain the balance of the vitamins and the hormonal activity. It is also very, very essential for the nervous system activities, cell growth and regulation. That's the reason why if there is any sort of decrease in the thyroid, then we have different levels of slowing down in the body from the cellular level to the clinical manifestation of sluggishness. All right. So in the yesterday's class, we have talked about the hyperthyroidism and the hypothyroidism. In hyperthyroidism, there is elevated T3, T4 levels. Okay, and in hypothyroidism, we have seen that it can be primary, secondary, or central or tertiary. And then in hypothyroidism, we have seen that the T3, T4 levels are low and TSH is high in primary. And it can be secondary, leading to any other disease, or it can be central or tertiary, that is about the hypothalamic activity, which can be leading to the central hypothyroidism. Finally, the levels of the T3, T4 are low. As you know, that if you remember, I also just told you briefly about the physiology of how the thyroid is formed. Thyroxine hormone is formed, that is, the iodine is trapped and then it is getting oxidized. Then the organification takes place, that is formation of monoiodotyrosine and diiodotyrosine. The mono and diiodotyrosine combine to form the triiodotyrosine, that is the T3, and then 2-diiodotyrosine will combine to form the T4, right? So this is about the T3, T4 formation. As you know that these T3, T4 will be transported by albumin, transthyretin and thyroid binding protein. Okay, these are the proteins which will help. So in the form of, when it is attached to the thyroid globulin, it is in the form of colloid, which is stored. Okay, the normal histology is the lining of the cuboidal cells with the central colloid. Okay, and the parafollicular cells are present, which secrete the calcitonin, which is essential for the metabolism of the calcium, right? So this is about the physiology, anatomy, and then the hypothyroidism, which we have seen. As you know that the Graves' disease is the most common 85% disease contributing to the formation of the hyperthyroidism. And in hyperthyroidism, we have the features of palpitations, then excessive sweating, diarrhea, muscle pains, all of that. And the Graves' disease is mostly seen in three things, that is having a hyperthyroidism. The second one is having an ophthalmopathy, that is the exophthalmos. Then the third component is the infiltrative dermatopathy, or leading to pretibial myxedema. Okay, these are the things which you have to remember in the Graves' disease. And in the hypothyroidism, we have the neonatal or the childhood, that is the cretinism, and the adult type, that is the myxedema. In both the types, you have the loss of hair, you have the lateral part of your eyebrow getting lost, then you have a broad voice, then you have slowing down of your heart rate, okay, and then you have constipation, okay, all sorts of slowing down of your metabolic activity. So the patient will be stout in contrast to the uh, uh, lean personality that is seen in the hyperthyroidism. Okay, so we have also seen about the thyroiditis. Thyroiditis can be autoimmune, the Hashimoto's thyroiditis. And then we have come to now another thyroiditis or another inflammation that is subacute or otherwise called as dequervain thyroiditis. It occurs in 30 to 50 years age group females. It is very less frequent than Hashimoto's thyroiditis. In Hashimoto's, you have seen that there is an antibody that is present, then that is causing the Hashimoto's thyroiditis. So we see less number of thyroid follicular cells functioning, and there is destruction of the thyroid follicular cells with the lymphocytes. And then you see the Hürthle cells, that is abundant eosinophilic granular cytoplasm, and the vesicular nucleus. That is in the Hashimoto's thyroiditis. I am telling you about Hashimoto's so that you can differentiate it well from the subacute or dequervain thyroiditis. So the etiopathogenesis, it is due to mumps, measles, and adenovirus. Okay, here that if there is a viral infection initially in the patient, this viral infection will release an antigen. And this antigen is presented by the macrophages with HLA-B35, and it then stimulates the T lymphocytes, which will damage the thyroid follicular cells. Okay, this is in contrast to the autoimmune disease that is self-limited. So here is the pathogenesis of subacute. See, initially it is affecting the upper respiratory tract, the virus, something like mumps. Okay, then an antigen is liberated. Then the antigen is presented by macrophages. Then it stimulates the T lymphocytes, which is damaging the thyroid follicular cells. So coming to the other one, that is a granulomatous thyroiditis. So what we have seen as autoimmune thyroiditis, Hashimoto's, subacute or dequervain, and the third one is granulomatous thyroiditis. Here we are seeing it's less common. It is 30 to 60 years. Pain is present. It is usually associated with fever, fatigue, and myalgia. Post-viral syndrome. Genetic association is with, again, HLA-B35. There can be patchy microabscess formation and granulomas with giant cells. See, the definition or the term itself will suggest you that there are granulomas with giant cells. So, in addition, there is patchy microabscess, and that can sometimes lead to the destruction of the thyroid follicular cells, and then there is inflammation. So, that is causing hyperthyroidism. It deals with normal function. So, though it is happening, it is transient, and usually the subacute thyroiditis and granulomatous thyroiditis, the thyroid function gets normal. So, here we have the morphology, the variable enlargement of the thyroid. It is singular, both lobes enlarged, symmetric or irregular, firm. It has yellowish and rubbery consistence. So, this is the microscopic involvement. Initially, there is a disrupted follicle with neutrophil infiltration that is forming the microabscess. In the later stage, you have the lymphocytes, macrophages, histiocytes, and plasma cells playing the role. That means acute and chronic kind of involvement is there. Then we have seen the giant cells, and sometimes there can be fibrosis. So, here you have to remember that these subacute lymphocytic thyroiditis or the granulomatous thyroiditis are not having any Hürthle cells, which are prominent. Okay, and then you are not seeing this microabscesses formation in Hashimoto's thyroiditis, whereas you see the microabscesses formation here. And then the giant cells and the granulomas are characteristics of the granulomatous thyroiditis, right? So here we see the dequerence, that's subacute granulomatous thyroiditis. See here you are finding lot of giant cells. You see the numerous nuclei present in one single cell, right? These are all the giant cells. You see that there is a little fibrosis here, and then lot of neutrophils forming the microabscesses. This is the microabscess and the giant cell. Okay. So the clinical features, as you know, it is caused by some antigen which is producing an antibody reaction to it, and this is transient. So obviously it has an inflammatory reaction to it, and this is causing fever, anorexia, and pain, which is radiating in nature. Okay, there can be transient hyperthyroidism, but this is transient. The normal thyroid function will be there without treatment also in 4 weeks. This can be followed by hypothyroidism. Okay, so all these features will become normal in 8 weeks. So we've seen about the granulomatous thyroiditis. Now it is about the lymphocytic thyroiditis. Okay, it is usually again associated with DR3 and 5. Increase in antibody to thyroglobulin. Positive family history is present here. Okay. So what do you see in the morphology? We see mild enlargement of the thyroid gland, multifocal infiltration of small lymphocytes with disruption of the follicle. Plasma cells and germinal centers are not seen. Though it is called as lymphocytic thyroiditis, the reactive follicle-like appearance which we saw in the Hashimoto's thyroiditis is not seen here in the subacute lymphocytic thyroiditis. So here this is painless hyperthyroidism with palpitations, tremors, tachycardia. See, hyperthyroidism, whatever causes is causing the same damage. Okay, the thyroid is diffusely enlarged and there is increase in T3, T4. Radioiodine binding is reduced. So we have seen autoimmune thyroiditis, Hashimoto's thyroiditis, where there are Hürthle cells, reactive germinal center, lymphocytes, disrupted follicles. Then we have seen the subacute granulomatous thyroiditis, wherein the presentation is viral and the antigen is presented to the macrophages. Then there is a T lymphocyte or cell-mediated reaction that is happening. Then in the morphology, we see that there is pain, fever, malaise, and then we have in the microscopic picture, we have this granulomas, and then there are lymphocytes. There is an early stage where you see the patchy micro abscesses, and in the later stage, you find the granulomas, the giant cells, all of that. And there can be fibrosis. And coming to the next one, that is the lymphocytic thyroiditis, wherein there is disruption by the lymphocytes of the thyroid follicles, but it is not forming a reactive germinal center like that of the Hashimoto's. And then there are no prominent Hürthle cells here. So that's how you differentiate all these thyroiditis. And the last one of the thyroiditis is the renal thyroiditis. In the renal thyroiditis, we see that this is a mimicker of a carcinoma because in the renal thyroiditis, there is extensive fibrosis that is happening. Even that fibrosis can extend to the other parts of the neck. So what happens when there is extension to the other parts of the neck? We may think clinically that as a carcinoma, but this is a non-neoplastic condition. Okay, so this is an uncommon fibrosing lesion that can penetrate into tissues and then the contiguous neck structures. And because of this extensive fibrosis, there can be glandular, that is a thyroid, normal thyroid functioning cells are reduced. And then whenever there is no functioning component of the thyroid, what happens? There is decrease in T3, T4. So there is hypothyroidism. So it is always mistaken for a carcinoma because it is stony hard in nature and because of its extensive proliferating activity. So we've seen about all the types of thyroiditis here. Now we are talking about the goiter. Goiter is an enlargement of the thyroid gland. It can be diffuse or it can be in the form of nodules. That means the right side lobe is more enlarged than the left. On the right, you find 2 nodules protruding. On the left, you find 3 nodules protruding at the same time. So it can be diffuse enlargement, that is enlarged total neck, or you can see nodule enlargement. Okay. So that is the multinodular goiter or a diffuse goiter. Okay. So why this goiter happens? Whenever the hormone synthesis is decreased by the thyroid gland, it stimulates the pituitary TSH. We have seen that TSH is produced by the pituitary, and that is releasing the signal for the thyroid to produce the T3, T4. As you know, the T3, T4 formation, that is the organification and the iodine trapping, are the major steps regulated by the TSH. So here we are having the TSH that causes stimulation of this thyroid gland, thinking that it is pushing hard, come on, you have to work and produce more hormone. Then it causes hypertrophy, that is enlargement of the cell size, and then hyperplasia, number of the cells are increased. So this causes gross enlargement of the total thyroid. Initially, any goiter is having, you just have a physiological appearance of the enlargement of the neck or the thyroid gland, but the hormonal state is usually kept euthyroid because the TSH is pushing the thyroid gland to work more and maintain the thyroid hormone level. So that's the reason why you are having a euthyroid state. Euthyroid is nothing but the thyroid hormone levels are normal in the body, but the overactivity is happening from pituitary to the thyroid, right? So the enlargement depends upon the duration and the severity of the deficiency of the hormones. So here you see, this is the enlargement you are seeing here. Okay, that's how the thyroid gland looks. So let us go to the first one, that is a diffuse or colloid goiter, diffuse non-toxic simple goiter. Okay, where the entire gland is involved, it is not in the form of any nodules. So this colloid goiter is filled with a colloid. Colloid is nothing but a storage hormone, right? So it is endemic. Endemic means consistent or persistent. You see the disease in that population in a particular region. Okay, that is endemicity. So due to less amount of iodine in water and soil, as in hilly areas, you find this iodine deficiency. We know that iodine is necessary for the thyroid hormone functioning. How the iodine is trapped, then it is oxidized. This iodine, which is oxidized, is going and combining with the tyrosine, and then it is forming the monoiodo and triiodotyrosine. They combine and form the T3, T4. I'm just repeating it so that you will not forget. So this iodine is not present. So either by dietary deficiency or absorptive defect. Then what happens? This iodine deficiency will stimulate the TSH to cause the increase in the gland size and cell size, and the number of cells are increased. So how to combat this? You have to supply with iodine. Then ingestion of goitrogens, where the absorption of the iodine is not taking place. For example, calcium, cabbage, cauliflower, turnips, etc. So we've seen about the endemic goiter now. Then you see about the sporadic goiter. The sporadic goiter, the frequency is very less, more in females of puberty age. And we've also known that there can be hereditary enzyme deficiency, that is either in trapping, organification, in thyroid peroxidase, dehalogenase, iodine tyrosine combining effect, something like that. Okay. Now coming to something else we spoke about a little yesterday is this hormonogenetic goiter. I told you in the last class that it is a biosynthetic defect that can cause a biochemical imbalance in the formation of the thyroid hormone itself that is responsible for this goiter. So there can be some hereditary enzymic defects that will interfere the hormone formation. So it can be autosomal recessive in transmission, and it can induce cretinism. What is cretin? In the last class I told you that it's Christ like, that means the person is like Christ like that they cannot do a sin, right? So the process of organification is deficient. Organification, formation of monohydrotyrosin, dihydrotyrosin, the combining the iodine and tyrosine, is a pendant syndrome where the hypothyroidism is associated with the sensory neural deafness. So we've seen about the diffuse goiter, there's colloid goiter and dyshormonogenic goiter. Then we come to a place where it is called as a multinodular goiter. It also has endemic and sporadic types, and sometimes if you are taking some thiocyanates, it can affect the iodide transport. In sporadic type, it's rare and it can be seen in females, young individuals. It has two stages, that is hyperplastic and the colloid state. Repeated attacks. See, initially it is forming a simple colloid goiter, that is a diffuse goiter. The TSH is saying no, still the T3, T4 levels in the body, in the blood are not meeting the level which I want it to be. So that's the reason you work even more. Then there is more hyperplasia, more hypertrophy. Then what is happening? Initial the colloid simple goiter is now transforming into a multinodular goiter. So this is the later stage. So it depends on the deficiency of the iodine and it depends on the severity of the disease. Okay. So what happens? Hyperplasia, fibrosis, cystic change and necrosis. All these changes we can see under the microscope in the multinodular goiter. That is hyperplasia of the thyroid follicular cells, fibrosis, cystic change and necrosis. So as the thyroid gland enlarges, there can be mass effect here on the neck. It can press on the trachea, it can press on the esophagus. When it presses more on the esophagus, you have difficulty in eating the food. And when it presses on the trachea, you have difficulty in breathing. Okay. So rarely it can cause hyperthyroidism called as a Plummer syndrome. So what is Plummer syndrome? It is a toxic nodular goiter. How to differentiate it from Graves? It is not having any exophthalmos or infiltrative ophthalmopathy or dermatopathy. Dermatopathy, I told you, is because of the increased extracellular matrix deposition. So in the radioactive iodine uptake is uneven as we have the hyperplastic nodules. So this concentrated iodine appears as hot nodules. Its toxic thing can appear as a hot nodules that can occur in a long-standing multinodular goiter. So this is the microscopic picture of the nodular hyperplasia. You can see there can be this papillary projections. This is called as finger-like. You see the finger-like appearance here. And then these are lined by the thyroid follicular cells. And you can see that these cells are uniform, not showing any kind of change. That is, they look very benign in nature. Here you have the papillary hyperplasia, and here you are having lot of colloid, that is a cystic change, and here you can see the hemorrhage. Okay, so these are the benign papillary formations seen in the nodular hyperplasia. So as I told you, the morphology is depending upon the same thing, the hyperplastic phase and the colloid involution phase. So it is having an increase in size lined by columnar cells, and then once the dietary iodine is increased, once you know that there is some abnormality, some imbalance taking place, and then you replace the food having iodine, then the follicle which is proliferating suddenly droops down. Okay, so then what happens? The follicle involutes to form colloid-rich colloid goiter. So cut section, brown, glassy, translucent appearance, microscopy, the epithelium is clubbed or flat with increased colloid. So what are the clinical features? Majority of simple goiters are clinically euthyroid, that means TSH functioning, the push is enough to produce the T3, T4. The children with congenital defect induced cretinism, I told you, biosynthetic or enzymatic defects. Adults rarely hyperthyroidism, that is the plumber, that is the toxic multinodular goiter. The TSH is increased to less extent. So this is the goiter with the iodine deficiency. Here you can see the enlargement. And the multinodular goiter, again we see in the thing that it may be mistaken for neoplasia if it is large. So it is the same that the females can be affected, occurs in old age because it is a late complication. So initially the pathogenesis is same, that is initially it is diffuse simple colloid goiter and causes hyperplasia, then causes colloid involution. Again it thinks that the iodine is not sufficient, again hyperplasia, again involutes, again hyperplasia, again involutes. So these recurrent episodes of hyperplasia and involution, see once you are taking iodine deficient food, TSH says you have to push, gives T3, T4 hyperplasia, hypertrophy. Then there is diffuse enlargement, colloid formation. Then you eat food with iodine supplements or whatever you take, then again it thinks that yes, the iodine is there, the work is going on fine. So the TSH stops. Then the hyperplastic, whatever has formed, the hyperplasia, hypertrophy, the colloid and all, it involutes. Then again, you eat less deficient food. Then TSH is raised. Then it is giving a signal to the thyroid gland. And then it is forming hyperplasia again. Then it is again, you are eating good food. Then involution. So this hyperplasia involution produces irregular enlargement of the thyroid. So that is forming the nodules. It is due to the variations of the follicular cells in response to external stimuli such as the trophic hormones. So polyclonality and monoclonal nodules both exist. That means the genetic material which is there. Clonality means say one ancestor is producing one nodule, right? Polyclonal means there are many ancestors producing many nodules. Okay. So here we see asymmetrical enlargement, and then if it is very huge, very large, it will move like this. You know, it will cause a sagging effect that is called as the intrathoracic and the plunging goiter. It can almost reach your sternum if it is that large. Pathogenesis similar to the benign neoplasm. Follicular cells are heterogeneous for TSH response and replication. That's how the hyperplasia happens. Okay, that means heterogeneous for the TSH response means that see some cells are overreacting and some are less reactive. Okay, it is like they're not equally responding to the TSH stimulus. So one there is involution, one there is hyperplasia, one there is hyperplasia, one there is involution. So there is some irregular enlargement. So there is clonal proliferation of these cells with different proliferative potentials. Different proliferative potentials means the hyperplasia is happening at, for example, you give the same pad to two children, and one person is feeling encouraging, and you know he runs 10 kilometers further, but the other person thinks that okay, it's fine, I've done well, so just let's keep this, and then travels only 5 kilometers. So the same push for two different children can be different because of their occurrence. Okay, so cells have high potential for growth, oncogenetically active, and then these form the somatic mutation to form multiple nodules. So this uneven accumulation of the colloid tension stress lead to the rupture of the follicles and vessels. So this uneven hyperplasia, involution, and accumulation of colloid there, and then this cause some tension in the thyroid gland. So that will cause hemorrhage, scarring, and calcification. So in this cyclic manner, nodularity appears stroma enclose expanded parenchyma to form the nodularity. So what happens to the morphology? Symmetrical or asymmetrical? Obviously asymmetrical with different proliferative capacities and different nodules forming. And then you have this asymmetric enlargement. It can go on unless you give the treatment, and then it can go on to intrathoracic or splanchnic goiter, or it can just be unilateral. Okay, there may be a solitary nodule. So the cut section, the microscopy, before going to microscopy, we see the cut section. So as we cut the thyroid, we find multiple nodules which are well circumscribed, and then you can find the areas of cystic change, hemorrhage, and necrosis, which can be an evidence to the cyclical changes that are happening in response to the TSH in the thyroid. So in the long standing, it can propensate for carcinoma, but very, very less chances. Usually the MNG, you have papillary carcinoma that can be a risk. Usually either way, we see that the MNG may lead, it is not like a lead to formation of a carcinoma, because you find the polyclonal and the monoclonal nodules in the multinodular goiter. So in areas with iron deficiency with endemic goiter, high prevalence of follicular carcinoma has been observed. So in the MNG, in the polyclonal or monoclonal type, there are chances of micropapillary carcinoma and papillary carcinoma in a pre-existing multinodular goiter, but in areas with iron deficiency in an endemic goiter, you have a prevalence of follicular carcinoma. I'm talking about endemicity, right? So here we have this multinodular goiter with papillary carcinoma. I told you, see, usually you find the multinodular goiter that is not harmless unless and until the patient is experiencing the pleasure symptoms. Okay, but the multinodular goiter, if it just enlarges, goes intrathoracically and causes plunging goiter, then it can create a problem. In the meantime, if you're doing a scan, if you find some focus of Granulomatous type of calcification that can be associated with papillary carcinoma, then you have to do a total thyroidectomy. Then you have to put the patients on the thyroid supplements. So the papillary carcinoma and the follicular carcinoma can be associated with multinodular goiter, but in papillary carcinoma, usually we see that it is very, very essential for pathologists to differentiate between the papillary hyperplasia that is benign of a multinodular goiter with that of a papillary carcinoma that has a abnormal features of the nucleus. So these are again the colloid cysts that we find, this diffuse enlargement, the colloid cysts in the multinodular goiter. It means there can be multiple, see this 1, 2, and 3. So we can see these colloid nodules in the multinodular goiter. In the microscopy, we see that it is lined by flat epithelium filled with colloid. Some are hyperplastic, some hypertrophic. Degenerative changes means nothing but the necrosis, hemorrhage, and the cystic change, fibrosis, calcification. What all we talked about in as a consequence of this tension that is created with the cycles of hyperplasia and involution are causing the degenerative changes. So in the microscopy, we see that they are having huge cells lined with flattened epithelium. There can be hyperplastic cells, and then some are Hürthle cells. See, the Hürthle cells can be seen in two conditions as we talk about. One is Hashimoto's thyroiditis. The second one is multinodular goiter, where the Hürthle cells, I again describe you, that is abundant eosinophilic granule cytoplasm with vesicular nucleus. Some of the dilated follicles have conglomerate of small active follicles at one pole, so-called the Sanderson's bolsters. So this is nothing but you have a circle of the big circle. I mean, all the small follicles that are normally there are disrupted, form a big, big follicle, okay, that leads to a lot of a cavity inside where there is a cystic change, and all the cells which are there are present to one corner, something like your ring, okay, then they present to the one corner or at one pole, and then these cells form the active follicle. So that is called as Sanderson's bolsters. Okay, so I already told you about this. So the rupture of follicle may sometimes have a granulomatous reaction, like that of the granulomatous thyroiditis. Okay. So there can be a dominant nodule wherein the encapsulation is incomplete. The follicular sizes are variable, and then no compression of adjacent parenchyma. So this I told you, there is dilation, large follicle here. You see that there is a cystic change. Okay. So initially colloid cyst, you have cystic change. That's all with the colloid cyst. In the multinodular goiter, you have the thyroid follicular cells arranged in the form of nodules, which are of variable sizes. And then in some areas you see hyperplasia, in some areas you see hypertrophy, in some areas you see cystic change, and in some areas you see that big cystic change with all the small active follicles forming a conglomerate at one pole called as the Sanderson's bolsters. And you can see all the degenerative changes like hemorrhage, necrosis, calcification, fibrosis, and also the cystic change. Right? This is about the microscopic features of both the diffuse simple colloid goiter to the multinodular goiter, and the multinodular goiter has benign papillary hyperplasia that has to be differentiated from the papillary carcinoma. There can be associated multinodular goiter with follicular carcinoma, or a multinodular goiter with papillary carcinoma can exist together, right? So with the clinical features, the cosmetic importance because of the size, there can be dysphagia if it depresses backwards to the esophagus and the trachea. Utero state can be present because TSH is trying to maintain the thyroid levels. Okay, it may mimic neoplasia, and the hyperfunctioning nodule, if it is present, is hot. So that is about the thyroiditis to the nodules that are present as a result of the imbalanced activity in the thyroid gland. So in the next class, we'll be talking about the thyroid neoplasms, including the carcinomas. Thank you.